hypersensitivity can kill people. You need to be able to identify which hypersensitivity reaction is going on in your patient right here in front of you in order to decide what to do next and whether you should be concerned or you can just let it pass. So let's go through each piece of this and put it all together at the end. We're going to start with urticaria. Urticaria is a type 1 hypersensitivity reaction. It's all about the mast cells degranulating. Anything that causes mast cell degranulation can cause urticaria. But what I want you to remember is that IgE cross-links mast cells, leading to release of histamine. And if histamine is released, capillaries dilate, they get leaky, and they leak out a proteinaceous fluid around the capillary in the skin, which gives the classic presentation of urticaria, which is the wheal. You're going to have an annular, which means like a circle, red papule that does blanch when you push on it. Now, this sort of degranulation can occur from anything, not necessarily IgE cross-reactivity to an antigen. For example, a bee sting can do it, but so can a hot compress. So it doesn't matter what the insult is, if it results in mast cell degranulation, you're going to get histamine. And because it's based on histamine, not surprisingly, the treatment comes in the form of antihistamines. The only thing you need to do is decide, is there anaphylaxis? And anaphylaxis is a clinical diagnosis. You're looking for hypotension in response to an allergic reaction. Because if there is anaphylaxis, the right answer is IM epi. If no, you can treat normally, which is going to be steroids and antihistamines, both H1 and H2 blockers. If you give somebody epinephrine, you're still going to give them steroids and H1, H2 blockers, but it's epi first if anaphylaxis. If not, you can just treat it locally with either topical or systemic treatment. A drug reaction can be essentially any rash. But what you should look for on the exam is a pink, morbilliform rash that's symmetric and often widespread. And it occurs 7 to 14 days after starting a medication. So the medication you started today did not cause the drug reaction you're seeing right now. The diagnosis is made clinically. You just look at it and you link it up to a new medication. No biopsy is needed. To treat it, you want to remove the offending agent. That makes sense. Sometimes you may not know the one, but if you do, get rid of it. You still can use antihistamines for mild disease, and you can use steroids for severe systemic disease. And of course, if there's anaphylaxis, you're going to use IM epi. But there's one particular type of fixed drug eruption, which actually is no problem at all. The allergic reaction to a medication, a drug reaction, on subsequent exposure can cause a more severe reaction and lead to anaphylaxis. A fixed drug eruption is defined by the same rash in the same place every time you give that medication. It's actually totally okay. It's non-life-threatening. It's a little annoying or irritating sometimes for the patient, but a fixed drug eruption should not be seen as a contraindication to giving antibiotics. Erythema multiforme is very easy to spot. It's immune complex mediated, but it's the targetoid lesion. And they're found at acral sites, knees, palms, face, fingers. And if you see a target-shaped lesion, you should think erythema multiforme and Lyme disease, and syphilis. But erythema multiforme is most commonly caused by HSV, but it can be a drug reaction. Now, erythema multiforme on its own is not a big deal because it's a clinical diagnosis that you generally treat with topical agents, like topical steroids. Because it could be syphilis, because it could be HSV, you need to pay attention for those things. Right? So is it syphilis? Should you check for it? And the most common cause is chronic HSV. But erythema multiforme is the very first thing on a broad spectrum of a much more sinister and severe disease. And that's going to be the SJS-10 spectrum, Stevens-Johnson syndrome and toxic epidermal necrolysis. The difference between them is how much of the skin is damaged. And essentially, they're a spectrum of one disease. The patient is going to present with skin sloughing off. There's a positive Nikolsky sign, and the person is looking poorly. Let's talk about the differences between them, that is in the pathology and biopsy, but understand that it's the same disease in the way of treatment. SJS is going to have degeneration of the basal layer, whereas TENS is going to have complete thickness necrolysis. SJS is more dusky and can mirror erythema multiforme, like a more severe version. TENS is going to be the real sloughing of the skin, right? This is where entire sheets of skin fall off. SJS is less than 10% of the total body surface area. TENS is greater than 30%. Obviously, there's this overlap of 10 to 30, but you're not going to get asked that. It's going to be either the dusky appearance of erythema multiforme that involves 10% or less SJS, or full sheets of skin are sloughing off and it's greater than 30% for TENS. Effectively, these patients are burned. They lose their integumentary system and they need to heal. They're at risk for temperature dysregulation and electrolyte losses. So they need to be moved to a burn unit. The diagnosis can be made on a biopsy, but before you even get the biopsy, you need to put them in the right place. So you stop all meds. And you stop all medications, including steroids, because any medication can cause this. And you got to get rid of that stimulus, which is driving the disease. So you stop all medications. You move them to the burn unit, and then you pray. And what you have to watch out for is oral and ophtho involvement. If you have ophthalmologic involvement, you can actually go blind. Now, we're saying drug. What are the drugs that do that? You're going to see the same names over and over again as you talk about bad reactions to drugs. And that's going to be sulfa, penicillin, which sort of also means cephalosporins, but penicillins are worse. Antiretrovirals and anticonvulsants. Any medication can do it. But these are the ones you should look out for, and they can cause erythema multiforme all the way through TENS. But a sloughing disease may not necessarily be SJS or TENS. The last thing you have to know about is Staphylococcus scalded skin syndrome. The pathology is a staph infection that happens to attack the desmosomes that we talked about in the bullous diseases, effectively being a pemphigus vulgaris disease. The patient is generally going to be an infant with a febrile illness who then has sloughing of skin that starts in skin folds. That patient has a clinical diagnosis of Staphylococcus scalded skin syndrome and is going to need, and penicillinase-resistant penicillins like nafcillin should be started immediately. All right, so there's a lot of diseases that present either as drug reactions or skin sloughing off, and so they become really good fodder for the boards. What you're looking for is the area of body involved and the introduction of new medications. If you believe it's SJS or TENS, you pull off medications including steroids. If you think it's Staphylococcus scalded skin syndrome, you give antibiotics. And so you have to have the right clinical situation to know what's going on. Otherwise, the simpler diseases like urticaria, you simply spot it, okay, it's urticaria, and identify is there anaphylaxis. Drug reactions can come in the way of a rash all over the body, in which case the drug probably should not be given again, or a fixed drug eruption, which means it's the same rash in the same place, the same drug every time. Benign, just get through it. And we've got erythema multiforme, which is the beginning of that SJS-TENS pathway. That is hypersensitivity reactions.